Hi, everyone. Thank you so much for joining me today in my research in progress. And my advisors are Ann Irvin and Dr. Roberta Scherer. And what I'll be presenting on today is the association between tinnitus severity and mental health among individuals participating in the tinnitus retraining therapy trial. So on the agenda today, we're going to first go through some background, really the who, what, where, why do we care? And then aims. So my aims are consisting of some baseline findings and really what we're trying to gather out of this study. And the methods will further clarify how we will achieve those aims, in addition to a question to the group and enabling questions from the group. So what is tinnitus? Tinnitus is the perception of sound in the absence of an external corresponding sound. Tinnitus is not a disease, but is considered a symptom of some underlying health conditions and associated with hearing loss. And there are two main types of tinnitus, subjective and objective. Subjective tinnitus is far more common with a ratio of 99:1 comparing to objective. And the clear difference between the two is a pathological link. Subjective tinnitus is not linked to, let's say, traumatic brain trauma, etc. There's no real underlying identifiable pathological cause. And that is going to be our focus, and those are the individuals tested in the TRTT. So who was affected by tinnitus? The US CDC estimates that nearly 15% of the general public, over 50 million Americans, experience some form of tinnitus. 20 million people struggle with burdensome chronic tinnitus, and 2 million have extreme debilitating cases that affect their quality of life. The prevalence of continuous subjective tinnitus among adults affected ranges is from 5.1% to 42.7%. And this number came from a systematic review, hence why the range is quite large. The reporting of tinnitus is generally as an underlying symptom of other health conditions. So why are we looking at the link between tinnitus and mental health? What is the importance? What's the relevance? And past studies have indicated that individuals experiencing hearing loss and tinnitus have a higher prevalence of depression. In addition, a systematic review on the link between depression and anxiety among patients suffering from tinnitus indicate a strong correlation between tinnitus, anxiety, and depression. And there's a statistically higher association between tinnitus and psychiatric comorbidities. And this is why we're aiming to look at the prevalence and the effects of TRT on mental health outcomes. In addition, a recent survey from the British Tinnitus Association found that 23% of individuals agreed or strongly agreed that they had suicidal thoughts because of their tinnitus. 55% agreed or strongly agreed that tinnitus has affected their mental health. 53% said that their tinnitus has made them feel anxious. 42% feel that they have gotten social isolation, and 59% reported trouble sleeping and other forms of insomnia that are linked to mental health. So given this survey is pretty subjective and self-report, and that should be taken at face value. So the current treatments for subjective tinnitus are quite vast. However, they have very limited success. And some of those treatments include antidepressants, psychotherapy, acupuncture, cognitive behavioral therapy, masking, coping therapy, transcranial magnetic stimulation, and lastly, tinnitus retraining therapy, which is what we are focusing on today. So what is TRT? TRT is a structured treatment protocol that uses Jastroboff neurophysiological model of tinnitus to treat intrusive, often debilitating tinnitus. So it has two major components: directive counseling and sound therapy. Sound therapy initiates habituation of the reaction to tinnitus. So it's addressing the annoyance of tinnitus. And some people explain having tinnitus as after a concert, you feel this ringing in your ear, this annoying ringing in your ear. So maybe you've experienced it or have heard someone experiencing it. So that's kind of the annoyance it's trying to address. And then sound therapy, which facilitates the habituation of the perception of tinnitus, so the awareness of this tinnitus. So the tinnitus retraining therapy trial is a randomized, placebo-controlled, multi-center trial that aimed to assess the efficacy of TRT versus standard of care treatment in individuals who have self-perceived debilitating tinnitus and are seen in U.S. military hospitals. The study population are military personnel, and the TRTT was conducted in U.S. military hospitals. So kind of the reason of this is that individuals in the military tend to be exposed to these sounds, these large noises that can initiate tinnitus. And the prevalence of tinnitus in military personnel is actually quite high, with a large range of 6.1% to 75.7%. And in 2014, over 1.2 million veterans had a service-related disability for tinnitus. So just a little background on the demographics of the individuals in the TRTT trial. So the mean participant age is 50.9 years old. 44 were women, which was about 21.1% of study participants. 23.8% reported belonging to a minority group, and 11.3% were of Hispanic or Latino origin. So baseline tinnitus characteristics look at tinnitus duration, onset, and frequency of noise, which should be well distributed across all three groups and is measured by Tinnitus Questionnaire and other indexes. And the TRT treatment groups are split into 3 treatment arms: the full TRT, partial TRT, and standard of care. Full TRT is involving the directive counseling and a sound generator. Partial TRT is directive counseling and a placebo sound generator. And standard of care is quite directive, and I will describe that next. And everyone is going to be exposed to an environmental sound. So the directive counseling versus standard of care. So directive counseling is theory-driven, didactic, and directives, top-down approach. And the standard of care is very patient-driven, interactive, facilitative, and a little bit similar but different from cognitive behavioral therapy. And the TRT study visits are split up into your baseline study visit, eligibility visit, randomization, 2 treatment visits within 1 month of randomization and 1 month after first treatment visit, and follow-up visits at 3, 6, 12, and 18 months after the first treatment visit. And the outcomes for the TRT trial, the primary outcome was the change in TQ score evaluated longitudinally between the baseline visit and the 18-month follow-up visit. Secondary outcomes were also assessed longitudinally in TQ subscales, which is a Tinnitus Questionnaire subscales, the Tinnitus Functional Index and subscales, Tinnitus Handicap Inventory and subscales, Visual Analog Scales, the Euroqual, digit symbol substitution tasks, and other audiometric measures. So the conclusions from the TRTT is that all 3 treatment groups, full, partial, and standard of care, showed improvement measured by a significant decrease in TQ severity from baseline to 18 months. However, there was no difference between the treatment groups in change in tinnitus severity measured longitudinally. And the same pattern of improvement was verified in the 3 other measures of tinnitus distress. So the measurement tools, since there were many that were used in the TRTT, what we will be doing in this study is focusing on these 4 main measurement tools to assess the mental health outcomes related to tinnitus severity. And those include the state trait anxiety inventory, the Beck's depression inventory, positive and negative affect scales, and the Tinnitus Questionnaire to measure tinnitus severity longitudinally. So firstly is the state trait anxiety inventory, which is commonly used as a measure of state and trait anxiety. And it's used in research as an indicator of caregiver distress and can be used to distinguish anxiety from depression. Form Y is far more popular in research and has 20 items to assess state anxiety and 20 items to assess trait anxiety. So why these smaller subscales? What is state and what is state? Or what is state and what is trait anxiety? So state anxiety focuses on the right now and can be heavily influenced by stressful conditions. Someone's state anxiety can be quite high if they're experiencing some sort of emotional disturbance. And trait anxiety is a general feeling. So it is associated with probably your personality trait and how you experience stress generally. And then your total STAI score is combining both the state and trait anxiety. However, literature seems to support scoring and interpreting the S and T items of the STAI scale. And that's what we will do as well. So the Beck's Depression Inventory, FAST screen, was used in the TRTT, and that is a 7-question self-report instrument for the detection of depression. And this measures the severity of depression corresponding to the non-somatic criteria for the diagnosis for major depressive disorder, according to the DSM-5. The positive and negative affect schedule is a psychometric self-report Likert scale that consists of 2 10-item scales to measure both positive and negative affect. So positive and negative affect are highly related to personality traits, and positive affect can be related to attentiveness, activeness, enthusiasm, inspiration, interest. And negative affect is more related to irritability, feelings of guilt, distress, and individuals who are kind of jittery. So the scale helps evaluate positive and negative affect in that sense. And the Tinnitus Questionnaire is a 52-item self-report questionnaire that measures tinnitus severity. So the Tinnitus Questionnaire is split up into multiple different sections, and I think that we're going to be doing a subgroup analysis looking at the emotional and sleep subscales pertinent to our mental health related outcomes. And this is just a snapshot of this study indicating the different areas of the Tinnitus Questionnaire, and that includes the total score, emotional distress subscales, intrusiveness of your tinnitus, auditory perceptual difficulties of tinnitus, your sleep disturbance, your somatic symptom subscales, and all individuals to be eligible for the TRTT must have had a tinnitus severity of score of over 40 and must have been experiencing tinnitus for over a year to be included. So individuals in the study are experiencing some form of continuous subjective tinnitus. So that leads to our research outcomes and interests. So what we will be looking at, assessed longitudinally at 3, 6, 12, and 18 months of follow-up, is the mean change in S and T score, the mean change in overall anxiety score via the STAI, and the mean change in positive, negative affect, and depressive symptoms via the Beck scale. And secondary outcomes will be through subgroup analyses, exploring the effect of age, sex, race, and ethnicity on the mean change of all the respective mental health outcomes expressed in the primary outcomes. So the aims I'm going to pretty much be presenting as what we're aiming to accomplish via the primary and secondary outcomes, in addition to embedding some of the preliminary results that we have gathered, which are a sequence of correlations between baseline visit of tinnitus severity and, let's say, the STAI scale. So for AIM-1, we're aiming to analyze the change in STAI score stratified by state and trait subscales among individuals in the TRT group compared to the individuals in the standard of care group from baseline to 18 months of follow-up. And it's important to note that since we did not see a difference in efficacy between the treatment arms, we've decided to combine the full and partial TRT treatment arms to compare those against the standard of care. And so through that, after combining those and looking at the overall STAI anxiety score and tinnitus severity at baseline, we saw a positive correlation between overall anxiety and tinnitus severity among participants at baseline. And stratifying this again, so looking at state anxiety and tinnitus severity at baseline, we see again a positive correlation between state anxiety and tinnitus severity, meaning that individuals have higher levels of state anxiety compared to tinnitus severity. So high state anxiety, high tinnitus severity. In addition, trait anxiety, we also see a positive statistical significant correlation between trait anxiety and tinnitus severity at baseline in all our participants. So moving on to AIM 2, which is focused on the positive and negative affect scores. So again, we're going to be looking at the change in positive and negative affect among individuals in the TRT group compared to those in the standard of care group from baseline to 18 months of follow-up. And looking at tinnitus severity and positive affect at baseline, we see a negative correlation, meaning that as tinnitus severity increases, positive affect decreases. However, this was statistically insignificant, but we can still see an overall kind of relationship between positive affect and tinnitus severity. And looking at tinnitus severity and negative affect, we see a slightly positive correlation, meaning that as tinnitus severity increases, negative affect also seems to increase among individuals measured at baseline. And AIM 3 is to assess and describe the severity of depression as determined by the Beck's Depression Inventory among participants in the TRT group compared to the standard of care. And what we found was about less than 20% of individuals in the cohort had a clinically relevant score of depression. In addition, about 4% of individuals had reported suicidal ideation. So this is actually a very small proportion of the whole TRTT cohort at baseline. However, we're still going to try to explore this, even if we may not be powered to explore the differences between the TRT group and the standard of care group over time. So considering those three aims, how are we going to put it into practice? What are the methods that we are going to use to analyze these changes? So this is considered a secondary retrospective analysis on the TRTT cohort. We're combining the TRT, full and partial TRT arms into one treatment arm, comparing it to the standard of care. And the statistical analysis plan involves generalized estimating equations with robust variance to look at the mean change of the four outcomes. And for model selection, we'll be using forward selection of covariates with respect to literature on possible effect modification and confounding, and we'll adjust accordingly based on literature. Adjustments will be also made in respect to age, race, and ethnicity. And missing values were calculated via multiple imputation using SAS GenMod with 50 iterations. And so just progress to date, I kind of went a little bit quickly, but we first explored the correlations between key mental health factors and tinnitus severity at baseline to see whether there's even something worth exploring within this cohort of individuals that was studied. And we did find tinnitus severity to be associated with higher levels of anxiety and negative affect. We've developed a statistical analysis plan and epidemiologic study design for the TRTT data to assess the longitudinal data. And I've written the introduction and methods. So what's next? It's model checking, figure and manuscript development, completing the thesis, and presenting in April. So the big question we have for the group is, the big topic is mental health and tinnitus. However, I'm looking at anxiety, depression, positive, negative affect. Is there some sort of way to combine all these scores that have been previously measured to characterize mental health? Is there some way to take the self-report tools and characterize an individual's overall mental health? And does anyone really know about this? And that's opening it up to the
So this is Stefan. I wonder why you would like to combine them, because clinically you wouldn't treat an anxiety patient like you would treat a depressed patient, right? So I don't know why you would. And you can look at anxiety and depression separately, and you can, perhaps they develop differently.
Yeah, so that's a great question. So, and even some of these conditions are comorbid with each other, right? Like depression and anxiety. So I don't think we're going to end up combining a total score, but we wanted to explore the possibility of being able to paint an image of an individual with tinnitus and their respective mental health. But if you make a really good point that it's very different clinically, treatment-wise.
And if I can follow up, I have a question. Were depressive or the depressed and anxious people treated in some way? Because that would skew your treatment arms a little bit.
So the individuals in the treatment arms, let's see.
Were they treated for these? So if somebody screened positive for a depression, say, or somebody was found to be very anxious, were they treated other than by those assigned treatment? So was there extra treatment for some because of the mental health condition?
I don't think they were treated by the study staff or anyone involved in the TRTT trial, but if they reached a clinically relevant limit of depression or anxiety, they were given a referral to treatment.
Yeah, and if that happened differentially between the arms, you would want to account for that. So if that data are available.
Right. Okay. I'll definitely look into that.
I wonder, is one possibility, it would be, a real big simplification. It wouldn't be sort of really using the scores per se of each, but as a possibility, could you sort of, if you got those 3 separate conditions, could you look at the risk, say, of developing any one of them, or any pair combination or all 3 kind of thing? So so you could sort of then characterize it as then people with tinnitus, have maybe have a higher risk of developing any of these, or any particular combination or all 3.
Yeah, I think that begs a question of whether to kind of look at a prediction model of, based on these set of covariates involving tinnitus, what is the probability that you will experience depression, anxiety, etc., based on the data we have. I'm just a little bit hesitant because we only have about 151 participants, and I don't know if we're really going to be able to gather a prediction model that would be having great discrimination and good calibration in terms of its prediction ability. But I think that is where I would go with that.
Sure. Yeah, totally. I totally get that. I just wonder then, so what do you mean then, maybe I missed, by characterizing mental health, combining the scores, what are you sort of hoping to get at by doing that?
I think it was more so our group was trying to understand, okay, what does your tinnitus severity say about your overall mental health and your ability? So I think the direction would be towards that prediction model that we just kind of jazzed. But I don't think, like, now in hindsight, that there is really a way to categorize an overall mental health based on these different categories, because they're treated different clinically and categorized differently. However, it was just more so like an idea to kind of explore, to be able to characterize tinnitus participants.
And would that be sort of descriptive then, or would that be more like a causal kind of thing that you're trying to sort of look at and sort of start looking at? Because sort of characterizing just, tinnitus patients, exhibit these sort of characteristics versus, do you have what their mental state was beforehand and then afterwards maybe developing, or sort of any those sorts of links?
Right.
Well, this is sort of a simplistic approach. This is Barbara. You could look at correlations of some of the scales with different other scales or with different factors. For example, the positive and negative personalities, the correlations with some of the scales would be of interest.
Oh, okay. That's a really good idea. Being able to extrapolate based on the data that we have at hand. Thank you.
I also wonder what's the causal diagram? So what's the DAG? Is the theory that tinnitus leads to these mental health problems, or people who are prone to these mental health problems develop tinnitus more often? Maybe I missed that in the beginning. Did you touch on that, or is there a theory how things should work?
Yeah, so that's a really good point. So I kind of mentioned in the model checking and model selection that's where we're kind of headed next, because I'm still trying to understand whether we're having mediating relationship colliders, what really is the relationship between, let's say, anxiety and tinnitus severity, and that needs to be further drawn out and clarified based on the literature before I adjust for things like that and being able to understand that. But overall, I think our perception is that tinnitus severity instates higher anxiety. It may lead to more anxiety, may lead to depression based on the symptoms developed and the severity of those symptoms. However, mediation versus a causal relationship is something we're still exploring.
So do you have a diagram for this in your slides? Did I miss that?
I don't, but we'll have that done next time.
Yeah, I think you need some sort of theoretical framework.
Okay.
And I also might have missed this, I apologize. How do you deal with time here? So some people don't, they experience it episodically, or I mean, speaking personally, if I had it for a really long time, I'd be more anxious than if I had a brief episode. So how do you deal with time here?
So all individuals in the study were supposed to have at least 1 year of subjective continuous tinnitus. In addition, we have it measured, or we have tinnitus duration, severity, location, all in the questionnaires and different indexes that we have. So we could stratify based on, let's say, your tinnitus duration, based on your tinnitus severity, based on the location. And so we only have these measured, however, from baseline to 18 months of follow-up in the clinical trial data. So that's really our window and our ability to extrapolate those relationships.
Do you know what percentage of people had resolution? So you kept, you were saying about anxiety and depression being linked to severity. Do you have the data to allow you to see if there's a link to duration?
Yes. Let me see if it's in my slides. If it's not in my slides, it's in the publication, in I think table 2. And I can send the link to that. Yeah, so this is a tinnitus questionnaire, but then there's also the functional index that describes that, and that's in the paper for the TRTT.
And just out of curiosity, so why do you differentiate between the trait and the state anxiety? So it looks like the study goes to length and tries hard to differentiate the two. Can you comment on that a little bit and on the relevance?
Yeah, of course. So state anxiety and trait anxiety kind of measure different forms of anxiety that an individual can experience. State anxiety is heavily influenced by the moment. The questions in the form, the 20 questions revolving around state anxiety, is how are you feeling at that moment? And trait anxiety is more so focused on the longevity of the different symptoms of anxiety that you face, that is more involved with your personality trait. So one is kind of potential energy, and one of it is kind of like kinetic energy, if that makes sense. I've seen someone kind of differentiate that. And literature also supports separating the subscales to be able to understand whether an individual's state anxiety is heavily influenced. Let's say they had a really frustrating tinnitus episode versus how they're generally feeling anxiously.
And how do the two behave? So are they do they correlate a lot in your data?
I think they do, which is why the correlations look very similar. And that's also kind of why I separated them out. Yeah. Yeah, so you can see that the overall versus state and trait, the correlations look very, very similar. And I'm sure if I put them together, they will also be similar because of the patient population we have and what kind of tinnitus that they kind of have, which is continuous subjective tinnitus. But I think I will look at that even more in the correlation between state and trait.
Do you know if they are clinically treated differently, or I mean, I can see how you are using these differences to explain, you know, as explanatory variables. Are they clinically treated differently? Do you know that? I don't know.
I personally don't know. I would assume that trait anxiety could be treated differently, but I'm assuming based on the DSM-5 diagnosis of anxiety, that's really how the clinicians will go off of how to treat.
Emaan, if you're looking at the interactions between the anxiety and depression too, you might want to separate that out.
Okay.
Different effect.
Yeah, that's definitely on our list because of how comorbid they are. And that was our question for the group. And does anyone else have any questions or concerns? Oops.
Mind could you go back to your main question? Yeah.
This one?
There is a way of combining scores. It's called Hoteling's T-statistic. There's lots of assumptions with it, and typically people look at all the individual outcomes first. But it's an old test, but it's a way of combining multiple outcomes and getting a t-test between two groups. So you might want to look into that. I certainly don't think that should be your main or primary result, but it's something to look at. Okay, so Hoteling's T-statistic. The other thing, can you go back to your model? There was a slide on what you used in your model. It was generalized, that's it. Can you tell me what's in your model besides age, race, ethnicity? You got the treatment group.
Yeah, so Stefan kind of asked about the causal diagram, and we're still kind of deciding which covariates to include, but I think we're going to end up including severity, tinnitus duration, possibly location.
Is this a randomized clinical trial?
Yeah.
So you don't really need any of them because it's randomized. On average, they'll be the same.
Yeah. Yeah.
So the main thing that you're missing from there is the baseline measure of the outcome. So always include that. It's kind of like an ANCOVA technique. So you put in treatment group and you put in the baseline value of your outcome, and you're looking for change in the outcome.
Gotcha.
That would be my recommendation, is to always include that in your model. It's much more important than any of the baseline covariates that you're trying to adjust for, because since it's randomized, you probably don't need to adjust for that. I mean, you can, but theoretically, you don't need to.
Thank you. That's really helpful.
Okay.
I'm not sure if you have this, but because it was mentioned earlier, sort of, if somebody was diagnosed, they could be given a referral for treatment. Do you have, if they then sought out that treatment, if they then followed up with the referral and got treated? Because that would be maybe an important thing to put in there as well, sort of, whether people actually got treated for these conditions that you're interested in.
Yeah, that's a really good point. I did some exploratory analysis on what individuals did. I don't think that we have we have their life events, but I don't think we necessarily have whether they sought out treatment outside of the trial. I don't know if there was an explicit tool or way we measure that, but I can look further into that and see if there's any way we can kind of indicate whether someone received treatment.
No, there really wasn't. This is Bobby. I joined late, sorry. But no, the only referral we had was if they came in at baseline with a clinical diagnosis of depression based on the back, we required them to get a referral. But other than that, no, we didn't track anything.
Thanks, Bobby.
Hi, this is Janet. Did you know if they were receiving treatment at baseline for depression or anxiety?
We didn't ask that specifically. We did ask about medications. We could look at that, but no, I would have to say no. It was not a systematic. We did not look for that systematically.
Hey, Emaan, this is Lynn here. I've been having the same problem with depression and anxiety in my thesis as well, but I see that you are using the outcome as changes in mean scores. Is that correct?
Mm-hmm.
So has that been done in other studies? I think that should you should take extra care in doing that. You'll probably assume that that every item in this instrument is like additive, and all of those extra continuous variable that they're actually continuous and can be put in the t-test or something like that.
Yeah, so for the SDAI and the Beck scale specifically, I looked into the additive, I guess the additive measures, and it illustrates that we can, since it's a continuous measure, we could look at the change in the symptoms over time. Yeah.
Mm-hmm. And also with the question you posted about the depression and anxiety, I'm just concerned that maybe a lot of the correlation that you will be observing in the end probably comes from the two instruments that you'll be using. So do you assume that you have a population that is largely depressive, or I think I see from your previous slide that it has a low prevalence of depression from the beginning, and I'm just concerned that any correlation that you might observe in the end, if you plug in both the depression and anxiety model in your model, it probably comes from the instrument rather than what's happening with the population themselves.
Right, so I would be measuring each of the anxiety, depression outcomes and positive, negative outcomes separately. And I hear what you say about the correlation between the tools, and that's something that we'll explore ahead of time before kind of just throwing it all into the model and seeing what will happen.
Yeah, I'm sorry I missed the first part, but what would be the size of this population that you'll be working with?
So there's 151 participants, and about 20% of the individuals experience depression. And I think, I'm trying to remember, I think around 40%, I didn't present that, but around 40% had a clinically relevant level of anxiety. However, our big question is not whether we're going to be kind of diminishing clinically relevant anxiety or depression, but rather does TRT improve anxiety symptoms, depressive symptoms among the participants in our trial?
Yeah, I'm really envious of a sample size. I'm dealing at 70 something, but again, I think you probably see significant changes, but you just have to be careful how to interpret those two instruments that you'll be using together. I think in clinical care, they probably have a context of each individual about they have a maybe pre-test possibility of prevalence before they use each of these instrument. So you probably can look at the screening, whether these two instruments have been used in screening settings that would maybe justify your case more.
Yeah, I know for sure the Beck's depression scale is definitely a fast screen tool. The STI is a bit long to be the fast screen tool, but it's also heavily used in research and all the tools are well validated. But that's a good point that I'll look out for when I'm running the models.
Any other questions? Okay. Well, if that's it, then great job, Emaan. Thank you for presenting. Next month, we have Lynn presenting on January 25th. So we'll see you all then. Have a good holiday.
Thank you all so much.
Thanks a lot. Bye-bye.